morning, good afternoon. We would like to welcome you to today's virtual program, Real-World Insights on Treating Pinks, Reds and Purples with the Nordlys Platform, with Professor Peter Bjerring and Professor Firas Al-Niaimi. If you have questions during today's event, please enter them in the Q&A box. We will answer them at the end of the event. If you encounter any issues with the video or connection, please refresh your browser, as that will often fix minor issues. Google Chrome is the preferred browser. The information and photographs contained in this presentation are the property of Candela and its consulting healthcare providers, and are provided for global training, educational and discussion purposes only. Candela Corporation and its affiliates make no representations regarding federal, state, local laws or regulations that might apply to use and operation of this device. For this reason, please review your country's current indications for use as provided by the respective regulatory agency. By sharing this information, neither Candela nor any of its consulting physicians give you the right to use the information presented, and this content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Treatment considerations are under the discretion of the qualified licensed healthcare professional. Individual healing times, discomfort, treatment results, and satisfaction can vary. By participating in this webinar, you agree not to photograph, reproduce, or distribute any of the information or photographs presented during the webinar. With that, I am very pleased to introduce the speakers of this event. Professor Bjerring, a board-certified dermatologist from Denmark with over 250 scientific publications and 500 international presentations. His main interest is laser and IPL treatments. He has had various leadership roles in dermatology and is currently a clinical professor at Aalborg University Hospital. He is the past president of ESLD and the fellow of EADV, AAD, and ASLMS. Professor Firas Al-Niaimi is also a renowned dermatologist with over 210 publications and 400 global presentations. With more than 20 years of expertise, he trained at top UK hospitals and became the UK's first professor of laser dermatology. Recognized for his international teaching, he was honored with the Global Excellence Award as Consultant Dermatologist of the year 2019. Professor Bjerring, the floor is yours.
Thank you very much, Aviva, and thank you to Candela for inviting me here to this webinar. I'm really interested in this, and you know, my preferred topic is actually to talk about the Nordlys. So I'm really thrilled about this. Let's start with the basics. First of all, let's start about red skin lesions. What is that? Red skin lesions is actually just increased blood vessels in the upper part of the dermis. It can either be based on different diseases, as you can see here, and there are many possibilities. So let's talk about the basics, the basic mechanism behind red skin lesions. We do have, first of all, dilatation of normal blood vessels that are due to the inflammation of rosacea and acne and so forth, inflammatory diseases. It could also just be dilatation of normal vessels due to functional disturbances, as we see in vascular malformations with the lack of innervations, for example. We can also have growth of excess blood vessels, as in benign tumors like hemangiomas and cherryangiomas, or growth of excess tumors due to inflammation like we see in pyogenic granulomas, and also growth of excess blood vessels as part of a malignant tumor growth, as we see in basal cell carcinomas. Here we see examples of normal capillaries dilation due to rosacea, and what you actually can see here would be these linear vessels, which are distributed evenly on the skin surface here on the cheeks. If we look at inflammation here again, we'll just move through that. Here we see the port wine stains that are actually tumors with new vessels here in the histology. And these are mixtures of large vessels and small vessels. And if we see the excess blood vessels here in hemangiomas, these are real tumors, which are new vessels, extra vessels coming up here. And you can see they look quite differently in the dermatoscope. And again, if we move further down to excess growth, these are pyogenic granulomas, and they also contain lacunae of large blood vessels, as you can see. And for the last ones here, we can see excess blood vessels here, irregular vessels coming up into a tumor, which is often seen in nodular basal cell carcinomas. Right, let's move on to the basics of Nordlys. What is the Nordlys? The Nordlys is actually a Danish name for the spectacular phenomenon Northern Light, also known as Aurora Borealis. And the Nordlys is actually made here in Denmark, and it's based on a long row of clinical documented indications. These are just some of the publications that I have been involved with in the development of the settings for using the Nordlys the best way. There are many other authors that have also contributed very much to the documentation of the effects of this. And again, an IPL is not a laser. Laser light is monochromatic, only one color. It's coherent, moving the same way in the same phase, while the IPL is just a lamp with many different colors at the same time. The light is incoherent. It comes out in different phases, and it's not focused. It comes out in different angles. And therefore, we need to put on a filter in order to filter out the wavelength we don't want. And these can be different colors according to the different chromophores that we are actually addressing. And the lamps here are just ordinary flash lamps, as we know from cameras and other flash lamps. And then we have different colored glass in order to address the different chromophores of the skin. We also have a water filter, which will remove all the infrared wavelengths that would normally heat up the tissue water in the skin. That doesn't happen because the water inside the handpiece here on the applicator will absorb these wavelengths before they reach the skin. That will result in what we call selective waveband technology, which is quite unique. Other IPLs may need a thick layer of gel in order to filter out the infrared light before it reaches the skin. But with the Nordlys, this water inside the handpiece will filter it out before it reaches the skin. Therefore, you don't need a thick layer of gel as in other devices. And the filters of the Nordlys will give us possibility to deliver light from 400 nanometers up to 950 nanometers, depending on the different filters that we are using. In standard broadband IPLs, which have a wavelength band from 1000 up to 2000 nanometers that are absorbed in tissue water, that is not happening with the Nordlys, and that means that we don't need skin cooling in this case. And we do have different filters. The long wave filters here from 645 nanometers up to 950 nanometers are mainly used for hair removal in dark skin types. Then we have shorter and shorter wavelengths here down to skin rejuvenation with different wavelengths again, and down to 400 nanometers when we are talking about treatment of pigmented lesions. Then we also have neodymium YAG laser with 1064 nanometers, and we have non-ablative lasers 1550 nanometers and 1940 nanometers, which are fractional, which are also in the same platform. So Nordlys is a platform containing 3 different types of devices: the IPL, the neodymium YAG laser, and the non-ablative fractional lasers. So there are some ways to get selective photothermolysis, meaning that we only target the chromophore we are interested in without damaging the surrounding skin structures. And that is, first of all, achieved by controlling the wavelength bands, the pulse duration of the pulses, and the energies, as well as the treatment technique, which is actually easy to learn here with the Nordlys. That is because Nordlys has built-in clinical intelligence. What you need is only to tell the Fitzpatrick skin phototype, the degree of suntan, and the target size, large vessels, small vessels, and so on. And then the device will calculate the optimal pulse type and time and energy settings for you, which means that you have a very short learning curve when you start up using the Nordlys, and it's easy to delegate to your staff as well. And there's a special advantage of the Nordlys, and that is sub-millisecond pulses, meaning it can use very, very short pulses, much shorter than many other IPLs, which means that you get fewer treatments, you have equal or better result compared to the normal longer pulses, and there's a better control of the purpura threshold. And again, you'd only need very low energy settings compared to other IPLs, 5 to 6 joules centimeter squared, which means that you are not applying a lot of energy that you have to take away by cooling. So skin surface cooling is normally not needed. I have a long row of indications for using the Nordlys, but we're not going to talk about all of these today. That would be too much. For today, we'll talk about photorejuvenation, telangiectasias, rosacea, and poikiloderma of civet for the IPL part of the Nordlys. And then for the YAG laser, leg vessels, larger facial vessels, and venous legs. That's it. Let's talk about photorejuvenation first. Some clinical pictures here. This is after 3 treatments. You see the vessels on the cheeks reduced very well with a 530 nanometer applicator. And if you were looking at diffuse redness, which can be really difficult to treat, especially in this case here, which is erythema ochreogenes, and disease which is quite difficult to treat normally. But with the sub-millisecond pulse durations here, we can treat these, as you can see, after 1 treatment. You can also treat the combination of vessels and pigmentation. This is an example of reduction of the pigmentation in skin rejuvenation as well. Another one here, 3 treatments. 2 treatments, first with 555 nanometers and 1 with 530 nanometer. Again, a combination of pigment and vessel reduction here, the same here, after 2 treatments. Also, solar lentiginous can be treated very efficiently here. The same here. And more diffuse pigmentation, as you can see, hand pigmentation as well, solar lentiginous. And if we move on to telangiectasias, these are 3 treatments, again with the IPL, and 3 treatments again, more treatments before and after. And if we look at the treatment of active rosacea, where we have an active inflammatory component as well as dilated telangiectasias, then we might have an effect on the demodex because we are shortly heating up the skin, and we suppose that the demodex will actually die because of the heat. And if we look at this here, we can treat 3 out of the 4 different types of rosacea with the Nordlys. We are not treating the ocular type, but the other 3 types can be treated with the Nordlys easily. We are changing the pulse duration according to the size of the vessels, and the device will do that on its own. If you just tell it if it's small vessels, larger vessels, or big vessels, then it will change the pulse durations accordingly. And what you should look for when you're doing the treatment, what is the biological endpoint? And that is actually a darkening, immediate purpuring of the area you just treated. It disappears again after a couple of seconds, so you have to remove the applicator immediately after you have delivered the pulse, and then you will see a sort of purpura delay, which will disappear again. It's down here. And these are the kind of results that you obtain in rosacea, again after 2 treatments. And many people actually will claim that pulse dilators are better than IPLs. And this is not my experience, and not the experience either of Agneta Rubin from Sweden. She did this study where she did a split phase study where on one side the IPL treatment will be done and the other with pulse dilator. As you can see here, you get exactly the same result from the IPL and the pulse dilator after 2 treatments. Another patient here again treated one side with the IPL, the other side with the pulse dilator, and exactly the same degree of disappearance of vessels. I also studied the effect of patients on patients that were resistant to pulse dilator. There are a few that you cannot treat with a pulse dilator, and we treated those. And actually, we were able to get a good response in 46.7% of these patients that could not be treated with a pulse dilator when we treated with the IPL. And just a short mention of poikiloderma obsivat, which is actually a combination of pigmentation with dilatation of vessels at the same time. And there's also a little bit of oozing sometimes, so you have both melanin pigmentation and hemosiderin pigmentation together with the vessels. And these can also be treated very, very well with the IPL here. So to move on now to the neodymium YAG laser, which is a 1064 nanometer laser, near infrared, deeper penetration of the light through the tissue. We are using that for treatment of leg vessels here. These are a result from our colleague Michael Drossner in Germany, treating leg vessels. After 1 treatment, you can see a very, very nice result. Another one here, 2 treatments, very good results again. And even subcutaneous vessels can be treated. These vessels that you see here are not located inside the skin, but immediately under the skin in the subcutaneous tissue. And that can actually be reached with a neodymium YAG laser as well, because of the wavelengths of 1064 nanometer. Larger facial vessels as well. Here you can see periorbital dark circles. Periorbital dark circles are often a problem, can be caused by different things. Here you can see, first of all, veins. You can see chronic inflammation, as in the case of atopic dermatitis. And you can also have constitutional hyperpigmentation around the eyes. So there are different ways. But if we look at the vessels alone here, in this case, the reason here is that we often see with age a loss of subcutaneous fat at the lower eyelids and in the temple regions, which means that the vessels become more visible. And we also see an increased transparency of the skin in that area. And the reason for this increased transparency is that normally the collagen fibers in the skin are located in all different directions, but with age, they align in a linear fashion. And when you have collagen fibers in a linear fashion, they become transparent. And that is what happens here. So that's why we see these vessels more easily in elderly skin. And these vessels can actually be treated here with the YAG laser, because this is actually a very, very versatile device and is a good treatment. There's no disposables here. This is one of my patients, the vessel here before and just after. And you can see it was located here and it disappeared. Another one here and just after the treatment. And if you look at it after a day, you see edema. And after a week, the edema has gone. So again here, vessels in the temple. You can see we've treated this area first, the lower part of the vessels. You still see the vessels up here, and here the vessels have been treated, all of them. So it's a very good treatment, but you have to take care of the eyes, because eye safety is important in neodymium YAG laser treatment, because the penetration of the 1064 nanometer wavelengths is relatively deep, and that is why you have to take care not to get any damage to the eye. Venous lakes are also easy to treat. This is just one treatment, before and after. Very easy and very, very rewarding to treat. People are really happy about this treatment. You don't need any anesthesia for it. It's just one shot and that's it. So my conclusions here is that the Nordlys is a fantastic, effective device for treatment of all skin conditions with a vascular component. The treatment with IPL and YAG laser may be a good alternative, for example, in rosacea to medical treatments, because this can actually be done with no additional drugs or cosmeceuticals. And we can address both diffuse erythema, visible telangiectasia, and pigmentation, as well as visible subcutaneous veins with this device, with all the different components, the IPL, the neodymium YAG laser, and the fractional lasers in one single device, the Nordlys. Thank you very much. And with that, I will be happy to pass over to my colleague, Professor Firas Al-Niaimi.
Thank you, Professor Bjerring. Well, good morning if you are in the UK or in Ireland, and good afternoon if you are in continental Europe. It's going to be hard following you, Professor Bjerring. I just want to say that I'm also affiliated to Aalborg University in Denmark, and Professor Bjerring is not only a friend, but a mentor and a teacher of mine. So thank you, Professor Bjerring, for all your help. So I'm going to continue talking about the Nordlys platform, and I do have experience with it for a number of years. And what I want to do is just share some cases with you, and we can then have the questions and answers in terms of discussion. So my colleague has already mentioned that the Nordlys platform is not just one single system. So we have multiple IPL handpieces, which we already could see the variety of conditions that we could treat. There is also an ND-YAG laser, and also two non-ablative fractional laser handpieces, but those will not be covered today. So this is why we call it a platform rather than just a laser or an IPL, because it has multiple different handpieces. And this is particularly useful for clinics that are growing or expanding, or where new doctors might be joining in. Sometimes, like my colleague Professor Bjerring already mentioned, if you want to delegate certain treatments, so there might be some treatments such as the ND-YAG that will still be doctor-led, given the complexity of that wavelength, but some of the more straightforward procedures that may require the IPL on a lighter skin types, those can be, for example, delegated. So once again, the handpieces that come with different colors, those are IPL handpieces, and they will have different filters. Most commonly, the commonest ones that we tend to use will be the PR, the 530. So that gives you a narrow band wavelength of a band between 530 to 750 nanometers. So that's what we refer to as the PR. And then the other one that we tend to use is the VL. And the VL starts from 555, but it extends a bit longer to the 950. So the VL handpiece is what we typically tend to use in the slightly higher skin types, the 3 and the 4, or when you want to have more the advantage of the depth, because you have the longer wavelengths between 750 meter, which can penetrate deeper. Right, so I guess when you are facing with a patient, the common question is what parameters I'm going to use. So if we stick in this case for the purpose of this webinar on the vascular lesions, you'll have to make the distinction between, first of all, you take into consideration the skin type, because that will determine also the type of the handpiece that you are going to use. For the skin types 1 to 3, for the superficial vascular lesions, the PR handpiece will be the appropriate handpiece. For the skin types 4, with caution, of course, and you would need the experience with that, the VL handpiece will be the preferred one. And the reason being is that with the VL handpiece, we miss out on the very short wavelengths between the 530 to 555, so we have less strong melanin absorption because we are going to compete against the melanin in the higher skin types. But like my colleague Professor Bjerring already mentioned, for those deeper vessels, so the veins, for example, we're looking at leg veins, but even some of the venules on the sides of the nose, for example, those that typically appear purple, green, or blue, because of the anatomic depth, we Nd:YAG for them. So I already saw that one of the questions was about how to treat the spider veins or the diffuse redness. So for the diffuse redness, the superficial, the pink, red port wine stains, we use the PR or the VL handpieces. You can, for the telangiectasias on the face, also use the facial telangiectasia mode, but certainly for the reticular veins, the venules, we recommend using the Nd:YAG. And this is why in this platform we have a full vascular platform, because for some of the deeper lesions, you can use the Nd:YAG, and you sometimes may want to combine even the VL and the PR handpiece if you have a deeper component, let's say a purple component of a port wine stain. So we'll be using the VL handpiece for that component. And for the more superficial red or pink components, then we can use the PR handpiece for that. And again, just referring to what my colleague Professor Bjerring said, that you may want to start sometimes with a VL handpiece, clearing the deeper components, and then with subsequent treatments, if all you're left with is the superficial components, you can then move over to the PR handpiece. So this gives you the flexibility of switching between different handpieces. So again, you can see here that really, with the exception of the very high skin types, the 5 and 6, we pretty much can treat all different vascular lesions, ranging from diffuse redness to isolated telangiectasias, whether it's part of rosacea or not, to leg veins, venous malformations or venous lesions such as venous lakes, and all the different types of port wine stains. And with port wine stains, it's also important to mention that, particularly for the pulse dye laser resistant port wine stain, I find that the Nordlys platform works very well. And again, Professor Bjerring was one of the first to publish the data on that. And the reason behind that is that we have a larger handpiece spot size that penetrates deeper, but we also have different range of wavelengths, and therefore we're targeting vessels at different depths. Although here it says skin type 5 and 6 not to treat, for some of the skin type 5s, for some of the vessels experience using the Nd:YAG, I have treated some of those patients, but of course that will fall outside of the Candela manual guidelines. But with experience, for some of these vessels using the Nd:YAG, they can be treated. Right, so let's look at a very common condition that we often see, particularly in the lighter skin types, and that is poikiloderma obsidiata. Now, in my experience, definitely I do see that the IPL, the Nordlys, works much better than the pulse dye laser. And that is not really a surprise, because if you look carefully with poikiloderma, we don't just have a vascular component, it's pigments and melanin. In some patients, the pigmented part might be more visible. In other patients, or in most patients, it's more the vascular component that they tend to really bother about. So this is why the IPL would be better, because it will target both. But it's not just any IPL, and this is where the Nordlys IPL really works extremely well for the poikilodermas. And that is because you need to use a very short pulsation. So really shorter than 3 milliseconds, whereas most of the other IPL systems, 3 or 4 milliseconds being the shortest that they can use, whereas in this case, we can go down to as short as 1.5 milliseconds. And in some cases, I even go lower, down to 1 milliseconds. So really the take-home message is, with poikilodermas, the Nordlys IPL tends to work better. We don't need high fluences. This is certainly an area that is very risky of complications, and a short pulse duration works better. Again, here, if you look carefully just above the finger of the patient, you can see a hypopigmented rectangular mark. And this is because the patient unfortunately had hypopigmentation from a different type of IPL. And that is because when I looked at the parameters, the wrong filter was used and a very long pulse duration, high fluence. And as I mentioned earlier, this is an area of thin skin and prone to complications. So really, he was still happy for me to treat him with the Nordlys. And you can see after a single session, using a short pulse duration, so that's 1 to 1.5 milliseconds, needing very low fluence, and you can see very nice improvements. So really, again, once again, the take-home message is short pulse duration and the PR handpiece. This is just a short video of what already was mentioned by my colleague about the transient cyanosis. So that is just the slight darkening that will take just a few seconds before it turns red. You just need to be patient because sometimes and you get the purpura. Now, depending on what you're treating, that still may be downtime, that is the issue, but then you can just go back to your parameters and reduce the fluence a bit to just avoid that. So you might be just at the cusp between purpura and non-purpura, but that subpurpuric parameter often tends to work very well for poikiloderma, for diffuse erythema and rosacea. Port wine stains. Now, many would know me as a very experienced user of the V-beam, the pulse dilator from Candela, and I still absolutely love that device. And I treated many patients with port wine stain, and I was very much convinced that the pulse dilator was the only laser that could be used for port wine stains. But that all changed when I was introduced to the Nordlys platform, and I started using the IPL from Nordlys, where I could see very nice and fast improvements with the port wine stains. And again, that is using the same principle of getting a clinical purpura as an endpoint, using the short pulse duration. We have a large spot size, and therefore we can penetrate deep, and this is why we can get very nice results. When do I use the V-beam as opposed to the Nordlys when it comes to port wine stain? Good question. In kids, we do have the clearance for the V-beam for port wine stains, but also in some very tricky areas such as the upper eyelid. So if I have a port wine stain on the upper eyelid, I still use the pulse dye laser because of the safety to the eye and also the practical aspects. But for the vast majority of the port wine stains on the neck, on the cheeks or on the upper cutaneous lip, I can still certainly treat those with the Nordlys IPL. So another patient again. So if you look on to the lower part of her port wine stain, just on the cheek, on the mid-cheek, you will see that it looks more purple. And this is exactly what I mean by essentially using the combination of the two handpieces. So you don't have to commit to one handpiece per patient. So this lower border of her port wine stain, where it's more dark purple, I will start first using the VL handpiece because I'm penetrating deeper, I'm using longer wavelengths, and I will get good results using the VL handpiece first. Whereas on the upper component, where it's more red and pink, I'll be using the PR handpiece. So it's in the same patients, just the lower parts using the VL handpiece, the upper parts using the PR. Then after a few sessions, as the lower parts, the purple parts lightens, then I can just continue using the PR handpiece. So this is just an example of how you can combine between different handpieces. Someone's asking what parameters. Of course, that varies from person to person. You have to take into consideration the skin thickness, the skin type, also the clinical endpoints. But I chase purpura. So I do want to look for purpura, so I will match. So you can actually go on the settings and I like to see a bit of purpura. So if I'm not getting that, I will shorten the pulse duration, adjust the fluence until I get purpura as a clinical endpoint. But we can discuss this. Again, if you look here, so you start first with the VL handpiece. You clearly have this purple component with deep components. And then when you're left with just the superficial pink components, you can then move over to the PR handpiece. Right, this is a very good example of a patient of mine who, if you look carefully on the left-hand side, you can still appreciate to see some round circles. And these are circles from post-purpura using the V-beam, the pulse dye laser. And, she got a very nice clinical endpoint with a good purpura, but still the port wine stain was very resistant to treatment. So this is a classic example of a pulse dye laser resistant port wine stain that when I then moved over, started first with the VL handpiece for that lower component where you can see it's more purple, and the PR component for the upper part, which is more pink. You can see a considerable improvement in the port wine stain. It was actually astonishing. And this is exactly referring back to the paper by Professor Peter Bjerring, that for those pulse dye laser resistant port wine stains, when you move them over to the Nordlys IPL, at least 50%, half of them have shown that they will continue to improve. Logic being larger spot size, different wavelengths, different levels of penetration and targeting different vessels. So this is a very good example of how the Nordlys can come into the rescue of a dye-resistant port wine stain. This is again the paper that Professor Bjerring already mentioned. But even the very, very light pink port wine stain, where you might think, well, it's very difficult to treat. The advantage again here with the PR handpiece using the very short pulse duration, we go down to 0.5 millisecond, getting the nice purpura, getting the nice clearance, and we don't need high ones for these kids. Another example. So tips, I still like to see purpura for port wine stain. Typically, I like to do 2 passes, although you need to be experienced with that. You need to take into consideration the clinical endpoint. So my first pass might be slightly with a longer pulse duration. I look a little bit more for a color change. Then my second pass will be more the purpuric one. As I mentioned, for the more purple port wine stains, I'll start with the VL and then I'll finish off with the PR handpiece. So again, a short video just showing how easy it is to select. I'm not sure if it's actually showing, but it's very easy that you can just navigate through the screen. You select the condition, select the tin type, then it asks you about whether it's a pink, red, or purple port wine stain. It gives you then the suggested parameters, but again, with experience, you are able to adjust those accordingly. Rosacea, that was already extensively discussed by my colleague, Professor Bjerring, but again, what I would say is that for the diffuse redness, I prefer the single short pulse duration, so that is using the 1.5 milliseconds. When it's a mixed pattern, have some telangiectasias or inflammatory lesions, papules and pustules, I like to start first with a double pulse, the 2.5 millisecond double pulse. And then when the inflammatory component is cleared, just chasing the diffuse redness, I will then switch back to the single dot pulse. But again, we can discuss this during the Q&A. The other thing I'd like to mention here, so for example, this is straightforward, PR handpiece, double pulse, 2.5 millisecond double pulse, 10 millisecond delay. And you will start with 7. Obviously, she's a lighter skin type, so you might titrate a little up to 7.4. But what I would like to say here is that it's absolutely safe to combine this with topical or systemic therapy. Because often I will see patients who will say, oh, I'm on this medication, I know that I can't have IPL. That is not true. It is safe to combine with systemic and topical therapy. Of course, it depends to an extent on their skin barrier, their sensitivity, but I routinely combine treatments and you get better results on them. Many different publications and studies supporting that. You can see even slightly higher skin type, this diffuse redness, this can work very well with um, the Nordlys IPL. Again, if you look here, what the problem here is not the inflammatory component. You don't see telangiectasias. All you see is just pinkness. So in this case, absolutely the key here is to use a short view. The PR handpiece, 1.5 millisecond, and starting really from around 5.6 joule upwards. You just have to see the clinical endpoint. Now, everyone has a threshold. So in some patients, and this is again why some colleagues will say, in some cases, I might need to go up to 6.2 joules to see them, as short as low as 5.4, you might see it. Every patient has a threshold. So this is why it's difficult to give exact parameters, but the approach is the PR handpiece, 1.5 millisecond, and then try to look for the clinical. Another example of a patient who said I had many different vascular lasers. This is as best as it in pinkness. The key here is the PR handpiece with a short pulse duration looking. Again, here you can see double-leukosis. Again, you can feel that from the roughening of the skin, the papillar components, and that works very well again with. You can actually see some injection sites, some superficial blebs injection sites. And what I wanted to mention is that many years ago, I published on the combination of the V-beam with botulinum toxin, which is off-label for the flushing, burning sensation of rosacea, the neurogenic subtype of rosacea. Recently, there was a publication combining the IPL with botulinum toxin. It works well. It's ongoing using CGRP inhibitors for rosacea and flushing. And that's also one of the mechanisms of how botulinum toxin works, because it inhibits the CGRP pathway, which is linked with migraine, the neurogenic sensitivity. So some excellent research work is taking place now in Denmark on this field. But I just wanted to mention that. Again, it's very straightforward using the interface where you can select from the menu rosacea. You can select the skin type, and then it will guide you through the parameters. And what I would say is, what I always say to colleagues who purchase the device, take some time to just play around with the device. Just like you have a new computer and you play with it. Just type in rosacea, increase the skin type, think, why is it giving me a lower fluence, ulceration, and try to just think on all the logic behind those parameters, and then it will start to become easy. So just spend some time looking at the interface. Okay, so that's just the protocol. This is off-label, combining botulinum toxin with the Nordlys Platform. Okay, so this is one of the publications that I wanted to mention, and this is one. There are many others, but this is again recently in dermatologic surgery. It's entirely safe combining systemic therapy. In this case, it was oxycycline with IPL. Some will say, well, it's photosensitive. It might be photosensitive ultraviolet range, but like we explained, with this IPL system, we start with a 530 nanometer, which is in the visible light range. So there is no photo sensitivity here. Many years ago, when I was doing monochromator photo testing, we tested, they did not show photosensitivity to the visible light range, which is different from the ultraviolet light range. Okay, we have a short video here just on how easy it is to use. So this is another example where if you just want these telangiectasias treated, so in this case there isn't really much of that diffuse redness, just isolated telangiectasia. You can treat with the Nd:YAG using a small spot, but if you're using the IPL handpiece, in this case is the VL handpiece, given just a slightly darker skin tone and the depth, the purple vessels, but it's using the facial telangiectasia mode. So that is starting really from 10 milliseconds and not the short pulse duration. That short pulse duration is for diffuse redness. Okay, this was already explained by my colleague. So and then again, just the Nd:YAG, just to reiterate what Professor Bjerring says, when to use the Nd:YAG, you certainly use that for the thick vessels, the thick telangiectasias, the leg veins, the hypertrophic component for port wine stain, venous lakes, but it can also be used for some other conditions such as warts and onychomycosis, which is outside of the topic of today. This is just an image of the interface screen to just show you how easy it is to navigate your way through the parameters. So, for example, you can see this is the Nd:YAG that's been selected. So you select leg veins. In this case, we selected skin type 3, low tan, and then you have to choose, are you dealing with an arteriole, a very small red vessel, or a venal, slightly thicker, wider, blue, purple, green one. And when you select that, it's going to then suggest you the spot size, the pulse duration, and the fluids, which is fantastic, really, because this is where many practitioners, certainly when they're starting, struggle with. And then again, you just use the pulse duration or adjust the fluids. But I can tell you, having used this, it's a very good and safe starting point to start with. So if you look at a nose like this, you can trace the individual vessels on the nose, the thick vessels, with the Nd:YAG handpiece, and then what you can do afterwards, use the PR handpiece to treat the background redness. In these cases, you can clearly see the blue-purple vessels. They will be with the Nd:YAG. Again, and again, just a short video showing you how easy it is to use, and you actually see the clinical endpoint as you treat. Venous lake was already discussed by my colleague. Periorbital veins, I do reiterate, it's absolutely important to use ocular shields. Some will say, oh, but I don't know how to use it. Well, if you don't know how to use the ocular shields, then I don't think this treatment should take place, because it's absolutely essential that the eyes are pinned down. Aim away from the eye, so don't aim the spot size toward the eye, but away from the eye. But these vessels can nicely be treated, even temporal veins shown, leg vessels. So again, really just to reiterate and summarize what we talked about, it's important that first of all you check whether there's tanning. Typically, I like patients to have at least a washout period of 4 weeks if they have an active tan, because then you don't want the absorption by the light. Getting the right phototype, skin phototype, is important. And what I would say is, in case you are using, for example, the IPL on the arm for whatever reason, or if you're using it on the décolleté, sometimes these areas might be slightly darker compared to the face. So you don't just look at the phototype of the face. Someone might be skin type 2 on the face, but maybe on the décolleté they appear a bit darker. So you'll have to then take that into consideration and adjust the parameters accordingly. We don't need cooling with this IPL, and that is again because we filter out the longer wavelengths. But if the patient wants a bit of cold air, more just as a distraction or a little extra anesthesia, some patients have a problem, and I do not find that that will be detrimental to the effect. In terms of post-treatment, hydration and sun protection. So I typically ask my patients to use a repair cream or a post-treatment hydrating cream. I'm not going to mention any brands because there are many different ones, but I always say to my patients, skin needs to be hydrated, calm down a bit. I tend to ask them to avoid using any retinols or tretinoin or alpha-hydroxy acid on that day, or as long as it takes when the skin is still a bit red. So that might be 1 or 2 days. And of course, to use sun protection, which is important following the laser and IPL. So to summarize, we have 5 takeaways, really. You match the skin type and vessel depth. If you have higher skin type, you shift to the BL handpiece. If your vessels are deep, consider using the Nd:YAG. It's important that you get the diagnosis correct and look at the vessel size, because for the smaller, finer vessels, we choose a short pulse duration. For the larger vessels, we use a long pulse duration. For diffuse erythema, poikiloderma, we prefer a single pulse, short pulse. For visible telangiectasias, if you're using the PR or the VL handpiece, we recommend you start with a long pulse duration. But again, the device will guide you through that. So that will be starting from 10 milliseconds or longer. Cooling is added here for some patients more as a comfort. But of course, certainly with the Nd:YAG, there is the cooling embedded. So for the Nd:YAG, it's always really recommended to use the cooling. If you're new to the device, you want to do some test spots, that's entirely appropriate. And I always say start with a lower range of the fluids until you build up the confidence or get your clinical endpoints. Every patient has a different threshold. It's important to set realistic expectations. What do I mean by that? Sometimes patients might get 1 or 2 purpuric areas. They might swell a little bit or become red. That's entirely normal. Rosacea, it's never going to be just one single treatment, even though after one single treatment, many patients will be very satisfied, but it takes a number of treatments, and it's important that will be recommended. Finally, we are doctors, so we adhere to evidence-based protocols, and you will find on the Candela website, and if you discuss with your Candela representative, there are a number of webinars that we have, a number of white papers and clinical bulletins, and some peer-reviewed articles that were published by many authors, including Professor Peter Bjerring, on this device that you can obtain, read, and they will contain also some guidance regarding selection of parameters. So with that, I'd like to thank you all for listening, and I guess now we can go to the questions and answers. Professor Bjerring? I can see we have many questions.
We have a lot of questions here, yes, that's correct. One of the first questions here is from John Fisher. He writes here, we get good results with IPL on background redness. And when a patient has erythematous telangiectasia rosacea, however, they see little results on just simple spider veins. Please, could you cover this? Why? What would you say, Firas, please?
Okay. Is that question?
Sorry, you're breaking up.
Consider using the Nd:YAG. Okay. Hi. Can you hear me now?
Yeah. Now we can hear you.
You could consider using the. Yeah. Sorry. Thank you. You could consider using the Nd:YAG, but I think the most important thing is to look at the pulse duration. So if you have these spider telangiectasias and you're using the single pulse shorts, that will be too short for those vessels. So on that particular area, you might use the facial telangiectasia mode. So that is, for example, starting with 10 milliseconds, around 9 to 10 joules, and get the clinical endpoints, the color change or the spasm in those vessels. But for the rest of the diffuse redness, you can continue with a single pulse short. So you can either go for the facial telangiectasia mode, or you can switch to the Nd:YAG.
Thank you. There's another question here. Please, can you say how the system would work with phymatous rosacea? Should I answer that?
I guess with phymatous rosacea, yes, please.
How I see it is that we have a lot of enlarged sebaceous glands here, and these sebaceous glands are relatively more heat sensitive than the rest of the tissue, which means that they are actually amenable to the treatment with heat. So we will use the 555 nanometer applicator. I have even been using the red light applicator, normally suited for hair removal, just to heat up the sebaceous glands here. And it actually works really well. The sebaceous glands, they actually shrink. And again, we also have the vascular component. vascular component, of course, would be treated according to the size of the vessels with shorter or longer pulse durations, or even the YAG laser. The YAG laser can also produce the deep heating that we want. I've been using that in sort of in motion treatment, where I'm treating with fast repetition of the pulses and just moving the applicator over the area about 20 joules per centimeter squared, largest pulse, largest spot size, and just bulk heating the area. That seems to work in my experience. What are your experiences, please, Firas?
Yeah, I mean, I think this is a very interesting topic because I do see a lot of right environment. I agree with you. So what I always do is the vessels I chase in, so I will use the Nd:YAG for the individual vessels. I do still, I like to use the PR or the VL for the background redness, and I agree with you that. I haven't done actually this painting mode with the Nd:YAG. That's very interesting. But what I do like to use is the non-ablative fractional laser, the 1550, which we didn't talk about today, but it's, as you know, it's a fractional handpiece that we have to this platform. Because I find that also helps helping with the pores and overall the texture. With those patients, again, based on their activity, I also like to combine that with a low dose of isotretinoin. So I use the Nd:YAG for the individual vessels. I use the PR or the VL, but I haven't used the Nd:YAG in motion. That's a very interesting one.
There is a setting meant for onychomycosis, and that can be used. So you have a standard setting that you can use for this. You don't need to invent a setting yourself.
Yeah. Thank you. Looking through the... Okay. I'm just going through the questions. Was there any other question that, because a couple of them were repetitive questions?
I see a question here.
I guess. Yes.
Should I read that? If a vessel doesn't disappear on the spot with facial veins, can you double pulse? Can you double pass with a pulse after giving it time to cool in the same treatment session?
Yeah, so if I understand correctly, that if you hit a vessel and it doesn't disappear, whether you could do a double shot. Is that a question?
I think it is, yes.
Yeah, I mean, in a lighter skin type, I have done so in a lighter skin type, because you'll always have to also counteract the fact that there's going to be a little bit of melanin absorption if it's a higher skin type. But in a lighter skin type, yes, I would do a shot and then maybe just wait a couple of seconds and do another shot. Just in the same way I used to do with the V-beam, with the pulse dye laser, where we know that sometimes just double shots help coagulate, because you increase the temperature within the vessel, then you allow for a little bit of that cooling period, and then you shoot again. So in lighter skin types, yes, is my answer.
There is another question here where you say you refer to sub-millisecond pulse duration, but I did not see examples in your shown slides. Could you kindly give a couple of examples? I showed one example on the erythema ophryogenes patient with a very diffuse velvety redness on the cheeks, young males often. And I treated that with sub-millisecond pulse durations. That produced purpura. You cannot avoid that in that case, and you need purpura, and you need to tell the patient that it will happen. Otherwise, it's not possible to reduce that.
Yeah, I guess that's another interesting question: is when do you need purpura versus non-purpura? So when would you need purpura? I could tell you my perspective. Port wine stains, I still like to see purpura. Now, it doesn't have to be intense purpura, but I do like to see purpura. For the very, very resistant cases of rosacea and a lighter skin type, and in in rubra fasciae, just like you mentioned. So in those cases, I do like to see purpura, and also in hypertrophic scars. So if I'm using the PR handpiece or a very erythematous, very thick hypertrophic scars, I want to see a bit of purpura. So that is how I do things. So choosing a short pulse duration, titrating the fluence until I get purpura. I would like to hear from you, Professor Bjerring. When would you chase purpura using the Nordlys platform?
Again, exactly the same conditions in port wine stains. I think I need purpura in order to be effective enough. You can get results with no purpura, but it'll take you more treatment sessions. And you could discuss that with the patient, because if the patient requires no downtime, then you might go for the non-purpuric one, but it will take more treatments and will be more expensive for the patient.
Peter, I could see that there is an interesting question that you last time gave a very nice explanation about the fenestration within the endothelial vessel walls and
right.
stimulation of collagen. So that is the question when you're using IPL for photo rejuvenation. The question is, can you do, first of all, using a 555 and then a 530? And do you go for a single pulse or a double pulse? And I understand that you explained about the double pulse where you get the fenestration and the extravasation of the platelets and the collagen stimulation. So I'll be interested to hear your thoughts on this. Photo rejuvenation, does it make sense to do one pass with the 555, then a second pass with the 530? That's the first question. And the second question is it better to do a double pulse or a single pulse?
So if you are aiming at reduction of wrinkles, which means that you need new collagen formation, not only reduction of vessels, not only reduction of pigmentation, but if you really want to have a rejuvenation of the skin, then you need to induce collagen neoformation. And in order to do that, you will have to induce a wound healing response in the skin. And we would like to have that wound healing response not to be really visible. So what happens is that we actually we hit the vessels with a short pulse, and then the vessels will dilate, the capillaries will dilate. And because the capillaries only are composed of one layer of cells, they will fenestrate shortly and after the treatment. And thrombocytes will then disappear out of the vessels into the interstitium. And when thrombocytes are present outside vessels, that is a very strong signal of starting a wound repair process. So that's what the fibroblasts start. They sense the thrombocytes and all the mediators inside the thrombocytes quite close to them, not inside the vessels, outside the vessels. They will start a wound healing response. And that will go on up to 3 to 6 months after the treatment. Then the fibroblasts go back to normal production rate, and then you can redo the treatment. You will give a treatment, you will open up the vessels, thrombocyte will go out in the interstitium, and they will stimulate fibroblasts to produce new collagen. We did a lot of studies to find the right parameters to do that. We did suction blisters to take out interstitial fluid of the dermis and measure the collagen production rate. And what we could see is that if you applied a 2.5 millisecond pulse duration, a 10 millisecond interval, and a new 2.5 millisecond pulse, then you would induce most collagen production when measured 72 hours after the pulse duration. That was how we actually found that really interesting parameter, which is not, let's say, easy to understand why it happened, but it is all based by experiments. So that was how we actually came up with a rejuvenation setting.
Fascinating. I always find this explanation absolutely fascinating, and the level of research that you did on this to find out. Yeah. So basically, to answer the question to the audience, it's the double pulse which is the preset parameters of 2.5 millisecond double pulse with a 10 millisecond delay. And I guess the question is, does it matter if it's VL or PR handpiece?
That actually depends on the skin type. If you have a little darker skin type or pigmentation, you will use 555 nanometer. If you have a fair skin, you will use a 530 nanometers. That's basically it. But it all depends on giving the vasculature a shock so that the capillaries dilate. That's all.
Yeah, no, absolutely. So that's fine. So for the wrinkles, it doesn't matter if it's 530 or 555.
No. Both wavelengths will work.
As long as it's a double.
Exactly.
Yeah. Okay. So on the point of the thickness of the gel that you apply on the face, it's very interesting how you say it with the other IPL systems who have a broadband, you actually do need a thick layer of gel, because that thick layer of gel will going to filter out and absorb the longer wavelengths that are absorbed by water. Whereas in our case, we don't need that, because I still see many practitioners putting a thick layer of gel, and that's probably because they were used to the other IPL systems. Whereas in this case, we use a very thin layer of gel. Are you, do you think that if we use a thick layer of gel with a Nordlys, that we actually might reduce the efficacy?
No, not at all. We don't need that. It's as you say, it's something that we were taught by previous and other later systems, and not this one here, because this has actually built in this layer of gel inside the applicator. You could say that. So you don't need a thick layer. And also we are using this reduced spectrum of light, which again reduces the heat needed for the correct treatment. And again, that also makes it unnecessary to use any cooling. Of course, you can cool if you want, but I think if you are using cold air or ice packs or something like that, you would actually change the efficacy, or you reduce the efficacy of the treatment, because then you need more heat to heat up the skin to the correct temperature needed for the effect that you are actually going for. So you introduce another variable if you're using either thick gel, cold packs, or cold air, for example, because then you have variability in the treatment. It's not the case if you're just using a thin layer of gel just to connect the applicator to the skin optically. That's why we are using the thin layer of gel, not to have an air gap. And that is actually the only reason for using it here.
Not to have an air gap.
It's important not to have an air gap between the glass applicator and the skin. And that's why we're actually still using a layer of gel.
Because what would happen then if you have an air gap?
You're not sure to get enough light through the skin and into the skin. There will be reflections from the surface then, reflections that would reduce the amount of light that you actually enter into the skin. So again, you will get a variability in the treatment that you don't want.
This is fascinating. So not enough gel where you have an air gap, you're essentially going to have reflection and inadequate penetration, and too much gel, you're going to absorb too much of the light, or you're going to absorb too much of the heat. Is that what you're saying?
Yes, actually, again, there will also be a diffraction of the, if you have a thick layer of gel, a lot of light will escape at the rim, which is not the case if it's close to the skin surface.
And I think that leads me to the next question, which is the pressure required when treating. And I think that is actually very, very important, because that can make a difference between getting results and no results. Because you actually don't need any pressure. You just literally need to touch the skin, because with minor pressure, you can break the vessel.
And what, as I see it, if you are new to the treatment, it's good to have a thick layer because then you definitely are not compressing the vessels. But again, you lose a little bit of efficacy. If you're using a thin layer and no pressure, that would be perfect. If you compress the vessels, then you can have a more specific pigment treatment, because then you avoid to treat any vessels because you compress them. There's a way, there's something you can play around with here.
Yeah, I mean, that's what I do for a lentigo. So if I'm treating a lentigo with the 530 handpiece, just to give an example, I'm not choosing, for example, the picoway, which is the picosecond laser from Candela. If I'm treating just the lentigo, I actually do like to compress. And my logic is just the same as the logic of the compression handpiece of the V-beam, and that is you compress away the competing chromophore, which is the hemoglobin. So then the light is just going to be absorbed by the lentigo. So the only time I actually compress is when I'm treating a lentigo.
And when you're doing that, you avoid the purpura.
Yes, absolutely. For 100%, you don't get the purpura because you have compressed away the vessels.
Yes.
But you also get much better results in the lentigo. So I see that there is one question about doing double passes. The first thing I would like to mention is that, this would be outside of Candela's recommendation. Candela as a company will recommend a single pass. But as experienced users, there are cases where I might just use a second pass. But in this particular case, talking about lentigo, so when I, for example, treat a patient with photo damage, some erythema, with some lentigos, I will do the full face, with a single pass. But on some of the lentigos, I will then just go back and do the compression method. So just on the individual lentigos, I will compress, do that second pass to really just get that lentigo hit hard. And they will get the downtime where they will have, the darkening of the lentigos. But that's one way how I would do the second pass. I will go with the compression on the individual lentigos, getting that darkening.
We are doing exactly the same, calling it spot chasing. So
yes, brilliant, and it's a brilliant handpiece. I think I will let you choose one last question, and then I think, but maybe one last question you would like to pick.
Yes, I have. There was a question here about topical analgesia or anesthetic creams. Are you using that? Does these have a place in your treatment here?
I can tell you what I do, and I'd like to hear your. So one of the treatments I like to do is also called the light and bright. Yeah. Which we didn't discuss here, but that is the protocol of using the IPL handpiece followed by the non-ablative fractional laser handpiece, the 1550. So for that, yes, the treatment will be painful without anesthesia. So I will numb first, but I'm not numbing because of the IPL. I'm numbing because I'll be using the 1550 afterwards. And I don't find that the numbing is going to interfere with my outcome. If I'm not using the non-ablative fractional laser, I'm just using the IPL. In some cases of port wine stain, some patients say, I feel that a bit. Can I have a little bit of anesthesia? In those cases, I just put a thin layer of anesthesia, short duration time, to just take the bed job. So I do it just for port wine stains in some cases, and I do it when I'm doing the light and bright protocol, which is the IPL followed by the 1550 handpiece. But for standard poikiloderma, standard rosacea, standard photorejuvenation, I do not do that.
Brilliant. Thank you. I couldn't agree more. Thanks. And I think this actually concludes the session.
Thank you. Thank you so much, Professor Bjerring and Professor Al-Niaimi. And on behalf of Candela, we would like to thank you for your participation in this virtual meeting, and to all our audience. Once the meeting ends, a post-event survey will appear requesting your feedback. Please take a moment to complete this survey as it will help plan future virtual meetings. This concludes today's event. Have a wonderful day. Thank you.
Thank you.